Get started. Welcome and thank you for attending our webinar. I have some housekeeping notes before we begin. Because of sound quality, it is necessary to keep you muted throughout the program. If you have the ability to ask questions using the questions box on your control panel. As a provider of continuing education, ICS follows specific guidelines and regulations when presenting continuing education events. We appreciate your professionalism and honesty in accurately recording the number of CE hours you attend during any given program. We recommend you be on the webinar screen for the full webinar. The system can tell if you pull up another screen, such as your email, and will show you as inattentive during that time. ICS bases the amount of time you're attentive when considering your CE hours. Polling questions are asked during the webinar. They are also used to gauge your attendance and CE credit hours. You must have your pop-up blockers turned off or hold down your CTRL key in order for the polling questions to work properly. If the polling questions do not function for you, simply write down the question in your answer and fax or email it to me, or type it in your questions box. An online survey will display on your screen when you leave the webinar. Please take 30 seconds to provide us with valuable feedback. Today, we welcome Dr. Ted Arkfeld to assist us in implementing ICD-10. This 2-hour webinar is the first in a series of 4. We will be taking a 10-minute break at about 1:30. Dr. Arkfeld graduated from Northwestern College of Chiropractic in 1988. In 2007, after being in clinical practice for over 19 years, he became a certified professional coder and full-time compliance consultant. In the fall of 2010, Dr. Arkfeld and Genius Solutions launched the National Academy of Chiropractic Coders. This is the first national organization to provide education and a certification for doctors of chiropractic and their insurance staff. He has also authored 2 books and is a much sought-out speaker for state conventions. Join me in welcoming Dr. Ted Arkfeld.
Thank you, Denise. Thank you. It's great to be back talking to doctors in Iowa. I actually grew up across the river in Lincoln, Nebraska, so I'm glad to be speaking with you today on ICD-10, and I'm very excited that there's such a good turnout. With the delay in ICD-10, I was kind of worried that doctors would get a little apathetic and just kind of push this off till the time came closer. And really, this is the perfect time to start learning about ICD-10 and digesting some of the information, and then slowly start working that into your practices. So I'm very excited about being here. So without further ado, let's get into some disclaimers here. This ICD-10 program is based on the guidelines by CPT Codebook, ICD-10 CM information found in the ChiroCode Desk book. So there's a lot of resources that I use, and I'll let you know if I'm coming up with a personal opinion. I'll tell you this is my personal opinion. Otherwise, the resources you can definitely check and validate with what we're going over today. Every attempt has been made to make this presentation as current as possible, but as everybody realizes, healthcare is changing. It has changed dramatically within the last 6 to 8 months. It just seems like every time you turn around, it's changing. And one of the biggest changes, and it was actually a huge surprise for me, was the delay in ICD-10. I never envisioned that there would be any delay, and then Congress passed the tag team law with that, and decided to delay it till October 1st of 2015. This program has been endorsed. There was 4 to 5 of us across the country that received ChiroCode Institute endorsement to teach on ICD-10. And so there are 2 books that I'm going to highly recommend, one of which you just have to get. You have to get the ICD-10 coding for chiropractic from ChiroCode. There's no other book out there that I'm aware of that has condensed things down specifically for our profession. And we're going to take some little excerpts from this book later on when we get into some of the specifics there. The other thing that I recommend, the other book, is the 2014 ChiroCode Desk Book. And sometimes when I go into an office to review their policies and procedures and everything, first thing I ask for is, how old is your ChiroCode Desk Book? And you really want to keep within a 2-year period. Anything older now than 2012, you should be updating to a 2014. Are there that many changes? No, but there could be 1 or 2 that could alter your revenue cycle. So you want to make sure that you keep that up to date. Now, we're going to, at the end, probably the last 20 minutes of this presentation today, I'm going to have you actually start looking at ICD-9 codes and transitioning them into ICD-10. There is a free app to do this, so if you have a smartphone or a tablet, I'm going to give you a little time right now to go ahead and download this free app. It's called Find a Code, and what this will allow you to do is to plug in your ICD-9 codes, and then it will help with translating into the language of ICD-10. Now, you won't stop here. It just gets you going in the right direction, and we'll get into that more in just a little bit. So go ahead and take some time right now to download Find a Code, because you will need that to do some coding questions at the end of this program today. All right. With all the changes that are occurring, there is a tremendous amount of frustration in the profession. And a lot of the doctors and their staff are feeling a lot like this person right here. And we are going through monumental changes in healthcare, some challenges that are definitely facing the profession. Just to give you a brief rundown of those changes, back in September 23rd of 2013, HIPAA Omnibus, a new revision of HIPAA High-Tech, came into effect. So if you have not updated your HIPAA manuals and your HIPAA protocols and your privacy notices for your office, you should have done so by now. And if you do need help with that, at the end of this presentation, I'll have our contact, and we can definitely help you with that. But everybody should be updating or have updated their HIPAA. So that came into play. And then, with the start of 2014, we were scheduled to begin ICD-10, and that got delayed about a month and a half ago to October 1st of 2015. The other changes that have occurred is with Physicians Quality Reporting System, PQRS. You should be reporting 3 measures now on all your Part B Medicare claims, and that has been a switch from 2 measures of 2013. And if you're not doing that, you will face some percentage penalties in your upcoming Medicare reimbursements for 2015 and 2016. And then we have Stage 2 of the Meaningful Use or Stimulus program. There's new criteria for Stage 2. So if you've purchased an electronic health record, it's a certified EHR, and you're taking part in the stimulus program, there's going to be some new criteria. So all of this has started, really came in 2014, except with the new HIPAA. So there's just a lot of changes. I've been in practice, like Denise said, I graduated in 1988 from Northwestern, and I've never seen so many changes occurring in healthcare. It's a very fluid situation right now, and you know, we do offer compliance programs, but I don't even call them that anymore. It's more called healthcare administration. You know, so there's a lot of things that you need to keep up with within your office nowadays. So today, what we're going to go over is we're going to give you an introduction to ICD-10. We're going to give a little history on ICD-9, why ICD-10 is coming into play. We're going to show you some tools on how to take your ICD-9 codes right now and transition them into ICD-10. And we're going to take this in bite-sized chunks. Okay, so these 2-hour webinars over the next 4 weeks is going to be great, because I've done 6-hour, 7-hour seminars, and after a while it just was information overload. So we're going to break this down so we can take some of the anxiety out of this transition, some of the frustration and stress. Denise asked me before we went on if I recommend putting together a little slush fund to have in case there's a revenue cycle decrease when this transition occurs. And I personally don't. I think we have enough time to get all the fundamentals down that you'll be okay when it does hit. So for example, September 30th of 2015, you'll be using ICD-9 codes. October 1st, you transition to ICD-10. So this is spring training right now. This is the grace period. Just to answer some of the questions right from the get-go, no, you cannot start submitting with ICD-10 now. They would get denied. So really there is no practice run. It is you start on October 1st, 2015. Now, over these next few sessions, we will be talking about some coding fundamentals, especially in the next sessions coming up. And these are things that you can implement right now into your practice, because when doing the ICD-10 training, what I found out is that a lot of offices are not doing some basic coding fundamentals properly. And so we're going to cover that, so you can start that now, and then all you're going to have to do is translate to a new language, ICD-9 to ICD-10. So with that, let's get into the language of coding. And it is a uniform language that conveys medical information. Coding is organized alphanumerically. When used properly, coding gives a description of the diagnosis, medical procedure, or supply. In chiropractic, our coding mainly consists of work with the musculoskeletal and neurological systems. Those are our two main systems that we will work with. So let's get into a brief history of ICD. And ICD stands for International Classification of Diseases. And right now we're in the 9th edition, and CM is always at the end. So you'll see ICD-9-CM. CM stands for Clinical Modifications. So the history, it actually began after World War II. And what it was developed by was the World Health Organization. And they were looking at a way to have better statistics on mortality. And it just kind of grew into other statistics such as mortality and morbidity. So it's usually a new release every 10 years. ICD-9 was delayed by 5 years, arriving in 1975. ICD-10 came on in 1990, and all other major countries but the USA currently use ICD-10. ICD-11 is already under development with arrival in 2020, supposedly. I had heard rumors a couple years ago when ICD-10 was first brought up that there may have been just an absolute washover and head right into ICD-11, but that's not going to take place. ICD-10 actually was scheduled to begin October 1st of 2013, and they delayed it back to 2014 and now to 2015. So what else was affected? Well, HIPAA electronic transaction standards. So for the last year, year and a half, possibly even 2 years, anybody associated with electronic transactions have been gearing up for ICD-10. And this started with a change from the current version of, or the old version now, of 4010 up to a new version called 5010, and this was greatly expanded in direct response to handle the ICD-10 code set. So there was a lot of things that were occurring behind the scenes at the carrier levels, and even with your practice management software, they have been getting ready for this transaction with ICD-10 for a period of years now. So any electronic transaction for which a standard has been adopted must be submitted using version 5010. That went into effect January 1st, 2012. Okay, so if you don't use 5010, you are not HIPAA compliant. And then all services on or before October 1st, 2013 must be coded using ICD-10 code set. Well, not anymore. That's changed to October 1st, supposedly 2014, and now that's been changed to October 1st, 2015. All right, now this is the reason we have to do it this way, is this is a HIPAA mandated policy. Okay, and we'll get into that in just a little bit here. So the International Classification of Diseases 10th revision, clinical modification, is a newer U.S. version of the World Health Organization set of diagnosis codes, which will be adopted in the United States, now effective October 1st, 2015. For private practices, any non-hospital-based healthcare practices, this is just our diagnosis. Our CPT, our procedural terminology, stays the same. Now, if you're in a hospital, the hospitals have to change to ICD-10 PCS, Procedural Coding Services, and that is a whole different language. So we just have to change for our diagnosis. Hospital-based have to do both procedures and for diagnosis. So maybe it's not so bad for us. We are becoming a system, a healthcare system of numbers, and they play a vital role in healthcare. First of all, we have our CPT, our current procedural terminology codes. That's our new patient exams like 99201, 99202. That's our manipulation codes, 98940, 98941. HCPCS supplier codes, our tax ID numbers, the NPI, PQRS, EHR stimulus. You know, these are all, everything is all about numbers right now. And so the CPT, the tax ID, the NPI, ICD-9, these were all mandated by HIPAA. Back, I believe it was in 2007, 2008, the administrative simplification provision in HIPAA mandated one code set. So there'd be one CPT language, one ICD language, was the 9th edition. It brought in NPI numbers. Okay? So prior to that provision in HIPAA, you could have all sorts of different claim forms because it brought in the CMS claim form as the standard. Do you remember, some of you have been in practice for a while, you remember Medicare had the old A2000 manipulation codes? You know, so a lot of times when I was in practice in Arizona, patients would bring in their own claim forms. You'd have to handwrite those out. Well, because of this revision in HIPAA, it mandated these numbers. And HIPAA has undergone new revisions throughout the years. And again, most noticeably was back in September, the latest called HIPAA Omnibus. So we are becoming healthcare, just its numbers are playing a huge role. So let's get into ICD-10. It was originally developed in the early 1990s. However, the switch was not feasible with mainframe computers of the time. And the complete overhaul from 5 numbers to an alphanumeric and 7 spaces. So our old just 739.1, that language is totally different now. So we're expanded out. Now it's alphanumeric, and it goes out possibly to 7 spaces at times. There's an increase of 17,000 codes in ICD-9 to over 70,000 in ICD-10. Now, as chiropractors, are we going to be using 70,000 codes? No. But we are going to be using a lot more. There's a lot more specific codes for what we see clinically. And that specificity should equal into medical necessity. I can tell you, as a clinician, I love ICD-10 because many times I would see things clinically that I couldn't find a matching code or one that would be right in ICD-9. And that's not going to be the case now in ICD-10. So there's going to be very, very specific codes, and that's the reason it's very important that everybody understands their roles in this whole process. Doctors, I have to stress to you that this is not something that you can take and just delegate to your insurance staff, to where you take and get your most common ICD-9 codes and you say, okay, translate those over into ICD-10 and we're going to be good to go. That cannot happen. ICD-10 will be driven by your documentation. And for those of you who are asking, well, how can that occur? What kind of documentation am I going to need? We're going to go over that in the next 2-hour session, but just to give you a brief description, your history and your exam findings must be very, very specific. So to give you a real quick synopsis on that, let's say that a patient comes in and they have neck pain. No pain going down into the extremities, so just neck pain. That pain is made worse upon extension and turning to the right. So there's a decrease in their ability to check for traffic. Okay. On range of motion, there's decreased movement with pain in the C5, C6 facet joint on the right, on extension and on right rotation. You do a cervical compression test, and it was negative for eliciting radiating pain into the upper extremity, but did produce localized pain in the C5, C6. You do a maximum cervical compression, you find the same thing. Then you perform cervical distraction, and that relieved the pain. What we're dealing with now is a cervical facet syndrome, and that comes directly from the history, subjective complaints. You confirmed it with your examination findings, and it would correlate to your diagnosis. The reason the diagnosis now is so important is that your care plan must be based on that. And Medicare actually has categories. They have category 1, 2, and 3 of diagnosis codes. So in category 1, those are less severe conditions. They're going to give you less duration and frequency of treatment for that. Category 2, they're more severe conditions. They're going to give you more frequency, more length of care. And then we have category 3, like a radiculopathy, a disc herniation. You're going to get longer treatment possibility there. Okay, so now with ICD-10, if you can be very specific in your diagnosis, that should increase your medical necessity for your treatments. So when you go to fill out the prior authorization forms from some of your insurance companies, right now, if you're getting 2 to 4 visits, I probably would recommend looking at the diagnosis. If they are soft tissue and just pain diagnosis, that's probably all the payers are going to give you, is just a few visits. But if you can be very spot on and get to the higher categories and be very good clinically wise, you're going to increase not only your treatment frequency, your treatment duration, you're going to have more wiggle room on helping that patient. You're not going to be restricted to maybe an 8 visit. The other thing with ICD-10 in regards to medical necessity, Chapter 20 in ICD-10 is etiology or mechanism of injury, mechanism of trauma. And it is loaded with all sorts of mechanisms. Where this is going to come into play with seeing Medicare patients is that some of the carriers across the nation have taken a hardline stance with patients that have come into your office and began care. And let's say that you have Mrs. Jones, who is your 80-year-old Medicare patient, comes in with a low back condition. You treat her for 4 weeks, 6 weeks, release her from active care, and Mrs. Jones comes back in a couple weeks later or maybe a month later and with low back condition. Well, what the carriers don't understand is that Mrs. Jones has a chronic condition. They have a chronic condition of degenerative disc disease, arthritis, maybe there's a spondylolisthesis in there. So structurally, she's not as good as what she once was. She's not as sound. So that when she goes out, and especially now that winter is finally gone, I live in northern Michigan, we still have, we just saw some piles of snow left out in the woods. But people are getting out. They're more active. So Mrs. Jones gets out. She's starting to do some yard work, trying to do some gardening. Well, structurally, she can't handle the stresses like she used to be able to. So she's going to predispose herself to having more frequent exacerbations. Where you can take ICD-10 and really use it to your advantage when the time comes is that there's an etiology codes. We can explain why Mrs. Jones. So I'm sure there's gardening bent over. Because there's lots of codes there. That is called a mechanism of injury or a mechanism of trauma, and that happens to be a documentation requirement for Medicare. So now you document that, and then you place that in your diagnosis. I think that's going to help us with the medical necessity of these patients coming back in with exacerbations. That's what my hope is anyway. And it's also going to lead to better statistical analysis for why we treat patients and why our Medicare patients do come back in, and we need to keep treating them. So the anatomy of ICD-10, the way the book is laid out, is it has 3 volumes. Volume 1 is called the tabular list, and this is where you always want to get to when you finally end up at the appropriate code. You're going to start sometimes at the alphabetical index. So doctors, if you're not into the codes, and all you have to do is just write the diagnosis out. Write out spondylolisthesis, lumbar spine, and then your insurance CA can get to the alphabet, look at that in that section of ICD-10, and once she gets there and looks it up, there's going to be a series of codes, and she can go to that code section and then keep going in and delving deeper into the tabular list until she finds the most specific code for that condition. So there's 3 volumes, and you always end at the tabular list. I'm going to probably hit that over and over again. So what's wrong with ICD-9? Okay, well, we've outgrown it. ICD-9 is full. There are new subspecialties that were not there when ICD-9 first began. So there's a lot of new medical subspecialties that there's just no room in ICD-9 for these things. Many times there's no codes to correlate with what we're finding clinically. It's full. There's no room for expansion in ICD-9. So let's compare. Let's take a look here. ICD-9 versus ICD-10. ICD-9 lacks detail. ICD-10, very, very, very specific. ICD-9 has 17 chapters with almost 17,000 codes. ICD-10 has 21 chapters, and it's approaching 70,000 codes. Right now, ICD-9, we use 3 to 5 digits. ICD-10 is going to be sometimes 3 to 7 digits, and it's alphanumeric. This is one of my favorite aspects of ICD-10. ICD-9 lacks laterality. ICD-10 has laterality. What we mean by that is with anything involving the extremities, we now have a right, left, or unspecified code in ICD-10. ICD-9, its ability to expand is very limited. ICD-10 has adaptions for future technology or expansion capability. ICD-9, the codes are less specific. It limits data for research. ICD-10 is all about that. Specificity improves coding accuracy. And I want to get into this. I want to touch on how that will help us as a profession. You know, if we become very specific in our diagnosis and that we can relay that onto the claim forms, and we're very good at our coding, from a statistical analysis, we can start to prove what we've known philosophically wise in chiropractic for many years, that it works. We work. So we have to be able to provide that in research, and this is going to help us. One of the things that I am going to start doing is at the end of our diagnosis, if I have somebody that is coming in with diabetes or hypertension or some other comorbidity that I believe is going to affect or could alter the outcome, either slow the progression down, I'm putting that in now on the claim form. The claim form has been expanded. We now have 12 slots to put diagnosis on, and so I'm going to start putting that in. I don't recommend that everybody does that. I'm going to see how this works. I'm not diagnosing diabetes. I'm not diagnosing high blood pressure, you know, but I am letting whoever that could be reviewing our claims know that I'm treating these patients. And in the future, there is going to be some changes with the way networks are formed, and these things called accountable care organizations are coming into play. And briefly, and I'm not an expert on these things by any means, but from what I understand is that the family physician is going to be the hub of a wheel, and the spokes are going to be ancillary services such as chiropractic, physical therapy, and we're going to have a community of patients or a patient population that our team is responsible for. And if we can demonstrate that we're keeping our population of patients from unnecessary surgeries and hospital stays, that there's going to be a profit sharing with that. So one of these things that, you know, Medicare right now has a whole database. They absolutely understand on a yearly basis what it's going to cost to maintain somebody who is diabetic. So let's say that we have a population of, I don't know, 3,000 or 30,000 people that's assigned to our team, our accountable care organization. And a majority of those, or 50% of those, let's say, are diabetic. And all of a sudden chiropractic comes in, and we're able to decrease the management on those diabetes or hypertension or whatever condition you're in there. If we can show statistically that because of our inclusion that is decreasing the amount of hospitalizations or medical expenses, you know, I think that's going to be a really, really good thing. So, any questions so far? All right, keep moving right along here. Please, as we get going, if you have questions, I don't want to wait till the end, I'd rather take the questions and answer them, because there's a building block here with ICD-10. So I want to make sure that you're getting all the basics down here. So how will these new codes work? Well, there's injury codes that are now by site instead of injury type. They're expandable, again, higher specificity, which is going to use current terminology. There are some terminology changes. For example, neuritis and radiculitis is being replaced with radiculopathy. This is going to allow for better statistical analysis, and again, I hope that helps us as a profession. The seventh character, this is very important on any traumatic diagnosis, and for us, this is going to be our 839 codes that transfer over into S codes. So right now, our 839 subluxations are traumatic subluxation codes. Those are codes you should be using for your auto and work comp and any group health that is the condition was based on some trauma. Well, when those get carried over, there's a placeholder at the end, and it's called the seventh character. And we're now going to be responsible for what we call episode of care. And that's going to be either the initial visit, subsequent visit, or sequela, and I'll get into that more later. Codes assigned to each chapter are broken into blocks of one or more 3-digit codes each. Each block deals with specific diseases and associated symptoms. So that's the reason you can't just take, for example, find a code, plug in an ICD-9, and then go over and just settle for the first ICD-10 code. That just gets you started on that chapter, and then you've got to go in and you got to delve in. So you get to the first 3 digits. Now you got to go look that up in the ICD-10 code book and find it and keep looking, because you may need to put in right sciatica, left sciatica, unspecified. This is where the documentation drives ICD-10. Doctors, if you don't document what side or laterality of the sciatica, there is an unspecified code, but I wouldn't recommend using that too often. So again, there are going to be 3 to 7 characters in length. Each added digits add specificity to your code, what you're trying to get at. Character 1 is always alpha. We're going to be dealing mainly with M's. So our diagnosis codes are going to start with M. Our traumatic subluxation codes are going to start with S. Character 2 is always numeric, and then 3 and 7 are alphanumeric. Some codes will have an X in them. Some will have 2 X's in them, and you'll keep those in there. That is a placeholder so we can expand ICD-10. And then again, the 7th character is used for certain sections. These are for musculoskeletal injuries and external causes of injury. So let's briefly take a look at some of the difference. So right now, over to the left, ICD-9, we have our category. So we have 3 boxes here, and then we get into the etiology and manifestation. So we can go from either 3 to 5 codes. Now we're going either 3 to all the way out to 7 codes with ICD-10. ICD-9 is always numeric. ICD-10 is going to be alpha numeric, then we can do alphanumeric as we go on, and then there'll be an exception here. So to take a look.
I think we have a question, Doctor.
Okay.
Is there a bilateral code, i.e. bilateral sciatica code? We see bilateral osteoarthritis code for the knee, but what about sciatica?
You know what? That's an excellent question, and I got to tell you, we started doing the ICD-10 seminars last October, and I've been all around, and nobody has asked that question. So, no, there is not a bilateral. So how would you do that? How would you code a bilateral extremity? You would use the dominant side first and then use the second code after that. So if the dominant side was right, you would use whatever code for right and then go down to left. So right here we have our ICD-10. So we have, this is chronic gout. We start off with M1A 3120. All right, so this here, this code actually is for chronic gout due to renal impairment, left shoulder without tophus. What's really kind of neat about ICD-10 is that because of the specificity, it can replace sometimes 2 to 3 ICD-9 codes. And you'll see that right here. If we were to break this up into an ICD-9 code for this same condition, this could have gone on for 2 or 3 more codes. So sometimes there's a very specific code that addresses everything that you're seeing. So let's take a look. Our 739.1 segmental dysfunction, cervical spine, that's going to translate over into M99.01 segmental somatic dysfunction of the cervical spine. Our 839, our traumatic subluxation, is going to go over to S13.111, and then you see right here this placeholder, dislocation of CO-C1 cervical vertebrae. All right, now I need to clear this up because there is in ICD-10, there is actual wording called subluxation. So we have subluxation and we have segmental and somatic dysfunction for that translate over from our 739 codes. There is subluxation and dislocation that translate from our 839 codes. Right now, we're going to use a process called General Equivalent Mapping System, or GEMS. So when you look at a code in ICD-9 and that points you over to the ICD-10 code, that's the one that you're going to use for now. We don't know at this point how the payers are going to, if they're going to actually pay for what we call a subluxation, or if they're going to stay right now with this dislocation terminology. And I've had this question come up, well, isn't that against our scope of practice to be treating a dislocation? It is, but in the realm of things, the terminology, don't get hung up on the terminology right now. The subluxation in our world is totally different than the subluxation in the medical world, and the same thing with dislocation. You know, the terminology, even with radiologists, some of the terminology is different with herniated disc, bulging disc, so on and so forth. So just bear with me, follow the GEMS, and I'll get into that more later, and just carry it right on across. Then as we know more, if the payers, what the payers are going to choose on, you know, maybe they finally will assign subluxation to us, the chiropractic profession. So we're just kind of out in the open with that right now. So our pain diagnosis then, M54.2. Now most of the pain diagnosis, the ones that I've seen, there is a direct one-to-one code. So what I mean by that is 723.1 is you're going to end up with M54.2, cervicalgia. There's not a lot of other choices. That is not the case with our degeneration of lumbar or lumbosacral disc. You have to go in and really find the most correct. So right here, this is what I mean. The documentation, especially the site, is very important. So doctors, make sure you document in your x-ray findings where the degenerative disc disease is. Is it in the lumbar spine, lumbosacral? Because there's 2 separate codes for that. This is going to become very apparent with our disc herniations and disc displacements. There's a lot of codes with regarding that. So I would suggest with disc herniations, disc problems, that you really brush up on the terminology used by your radiologist on MRIs. I would also really brush up on your clinical findings to support disc problems. And just to give you a little precursor here, you do not need to have an MRI to substantiate a disc herniation. There is more weight given in your clinical findings than the diagnostics. The diagnostics are to confirm. So in preparation for ICD-10, we've had to change the claim form. The old claim form only had 4 diagnostic slots. Now, this one, which went into effect April 1st, so I hope everybody is using this one, the new claim form has spots for 12 diagnoses. So the primary diagnosis, you're going to read those across instead of the way it used to be, 1, 2, 3, 4. Now I'm going to give you some fundamental tips on coding right now, which will help currently with your use of ICD-9. The coding hierarchy that I recommend and ChiroCode recommends is that you should, if possible, a neurological diagnosis should be number 1, okay, followed by a structural diagnosis. If you have a functional alteration, that would come in, soft tissue after that, and then pain diagnosis. So for example, if you have a patient that presents with, let's say, sciatica. Okay, so that sciatic diagnosis with ICD-9 right now, and this will be the same thing for ICD-10, that hierarchy is going to hold true, except with ICD-10 it's going to be easier because ICD-10 could have both a structural or a neurological component and structural associated with it. So let's say you do sciatica in A. In B, you're going to put a structural diagnosis. So what's that? Well, think about what is causing the nerve irritation. What's causing the sciatica? So in B, it's going to be possibly a disc herniation code. Could be a degenerative disc degeneration code. It could be possibly a facet hypertrophy code. So something structural. Could be a spondylolisthesis. In the absence of all those, then if you have to, go ahead and use your 739 codes as a structural alteration. So we would have sciatica, and let's just say that it's 722.52, lumbar disc degeneration. That would go here. The next is I'm going to recommend that you put soft tissue. And so that's going to be either a muscle spasm or muscle hypertonicity. So that's going to either be 728.85 or 729.1. So your soft tissue is going to go here. And then in the final would be pain. That would be 724.2. Now again, when we get to ICD-10, there could be a radiculopathy with low back pain code. And so you'll just need one code. So what I'm going to recommend is that you may use all 12 of these diagnoses. You take and capture all your chief complaint. So you put in the order of the chief complaint of the patient. So if the patient has a low back condition, you fill out all the diagnoses related to that low back, and then you do that for every condition. So you follow that hierarchy for every secondary condition, tertiary condition. Right here, ICD-IND is the indicator. So right now your practice management software should be putting a 9 in there. And you're putting in your ICD-9 codes across. Come October 1st of 2015, this is going to change to a 0, and you'll change to alphanumeric or ICD-10 codes. All right, so now let's say that you have a patient that you were seeing in August and September of 2015, and then you see them also in October 2015. So the August and September, you'll use ICD-9. Starting in October, you'll use ICD-10. Now, what if you had to resubmit a claim for services before October 1st, 2015? What code do you think, or what language do you think you would be using? You'll be using ICD-9. So anything prior to October 1st on a resubmission, you use ICD-9. Anything after, you'll use ICD-10. Did I see another question here? Oh, okay. Yeah, we got a few questions. Oh, I love it. Okay. Let's see.
Do you want me to read them?
I got the bilateral. Sciatica, do we see bilateral osteo? Okay, what about sciatica? Am I correct that Medicare will not follow this hierarchy? And I have to put, yes, you are correct. Medicare never has followed that hierarchy to a certain point. And so let's talk about that. Everything that I just talked about with the hierarchy, with the neurological, structural, and everything, that is for your group health insurance, and that's for your auto, that's for your work comp. Now, with Medicare, there's going to be some minor revisions with that. So in A, under that same condition, you would use your 739.3, segmental dysfunction, lumbar spine, and then in B, now you come with the neurological. Okay, so you're going to do subluxation, neurological, subluxation, structural, subluxation, soft tissue, and then pain. Okay, so if you don't have a neurological diagnosis, you go next to put in a structural diagnosis. And then from there you do your soft tissue, and then you do your pain. So yes, Medicare does still they still will require subluxation, and you still use that hierarchy. All right, everybody good with that? And we'll hit this more as the sessions go on as well. Okay, so ICD-10, the chapters. So there's 21 chapters, and we will use some in the diseases of the nervous system. So we are going to use some of the G codes. But we're mainly going to be in that chapter 13, musculoskeletal system, the M codes, and then we're going to be in that chapter 20, external causes of morbidity, or the V codes. And I have some videos that I'm going to show you. It is absolutely ridiculous, the size of that chapter and all the external causes of morbidity that there are. All right, this is going to be, I can't even sugarcoat this. This is going to be very dry. It's going to be very boring. However, we've got to get used to it. We've got to get through it. There are rules when you start looking up these codes that you're going to see some things in the tabular list. And it's very important that you follow these, because otherwise the specificity won't be gained. Okay. So there is symbols or conventions. These are basically the rules. All right. So if you see a colored dot, it's going to say make sure you use additional digits. Okay. Just the 3 digits is not going to be enough. All right. I'm going to get through these here real quick. Excludes 1. When you get to the tabular list, it's going to give you your codes. And underneath there could be excludes 1, and there's going to be some other diagnosis codes. That means that you cannot code any of the ones listed under excludes 1 with the code that you're attempting to use. They cannot occur together. Right, so excludes 1, they can never code the same. And I'll show you an example of this in a little bit. where it gets a little confusing is that excludes two, because you would think excludes automatically after I just said excludes one, you can't code them together. Excludes two means there is a possibility that the both codes could be used together, that both conditions could occur simultaneously. All right, so I'll give you an example. We'll show that in just a little bit here. So you'll see a lot of these rules pop up. Code also. It means we're going to need something more. If you're going to use this code, we're going to need something more. On traumatic injuries, there's going to be a seventh character. You have to have that seventh character. Or if there is a placeholder of an X, you have to use the X. And then there's various abbreviations not elsewhere classified. This is another specified code used when a specific code is not available or not otherwise specified. This is another unspecified code. So we'll go over this in a little while here. ICD-10, the biggest thing, the most important, if you get nothing out of this, don't just stop at a particular code. Make sure that you're coding at the highest level of specificity. And you'll see this once you get into ICD-10. Inclusion notes after the 3-level classification, so you're going to get to M54. That gets you to the right area. Then you're going to work your way down and see what the additional placeholders, the additional characters you may need in order to get to the most specific. Follow the instructional notes. These are very, very important. Just remember, ICD-10, the instructional, this is a cookbook. If you just follow the recipe, everything's going to be good. Okay, so what we're going to do is we'll start to review the coding process. Denise, did you want to take a short break right now and then we can come back to this, or do you want me to trudge on?
Oh, no, let's take a short break. Let everyone refresh their coffee and what do you want to do, 5-10 minutes?
Let's do 10 minutes.
Okay.
I can cut them some slack because this is, I know they're pretty excited about this stuff. So let's do 10 minutes and we'll come back at 20 till. Will that be fine?
Okay, that sounds great. Thank you.
Okay, we'll see you in 10 minutes.
And Dr. Arkfeld, will there be a polling question soon? For those watching the recording, you can probably fast forward through this session. Dr. Arkfeld, are you back?
Okay, if everybody's back, it's 2:40. We still have a lot of material to cover, so I'd like to get going.
I'm back. Is there to be a
Uh,
polling question pretty soon?
yes, let's go ahead and what was that first one, Denise? It
Uh,
had to do with
the,
ICD 9.
yeah, the main reason for the switch to ICD 10. You want me to launch that?
Please.
Okay. If everyone will hold down their CTRL key, I'm going to launch the poll now. And the question, what is the main reason for the switch to ICD 10? You've got 3 choices there. It's not a test. It's just simply to gauge if you're sitting behind your computer right now. So and everybody's getting their vote in. We're at 79% good. I'm going to give them a little extra time to finish this poll since some may be just getting settled back in.
Okay.
So we're at 83%, which that tells me there's probably 5 or 6 out there who still need to get it in. And if the poll didn't pop up for you to use, go ahead and just type it into type your answer into the questions box, or you can write it down and fax it to me or email it to me. We're at 86%. Still some out there we need to get the poll from. I'll allow another, let's try another 30 seconds because it is 2 minutes after, so everyone should be back. Okay, I'm going to go ahead and close the poll, and I'll share the results. And can you see those results?
I sure can.
Yeah, which was correct?
All right. Well, if you answered HIPAA mandated, you were correct. There was 3% that said to catch up with the rest of the world, and 42% ICD 9 is outdated. But the real reason it is a HIPAA mandated language now. So, all right. And I did see that there was a question, will our EHR systems help us or prompt us to increase the speed and efficiency of the new codes? And to answer that question, which is it's a question that I've been hearing a lot, and it hasn't been just with the practice or the EHR, but the practice management systems. Yes, I believe that your vendors are working to make this transition as smooth as possible, and to give you some tools in order to help with that process. And that's the reason, even though I am a huge fan of ICD-10, I am also a bigger fan that it did get delayed. And the reason is we weren't ready. You know, we weren't ready as a profession. Some of the vendors, and there's 2 that I work with specifically, and I can tell you that we just weren't ready to help the profession with some tools to help you with this. Because one of the ways that I've described this transition is, you know, how easy would it be that you're speaking English in your office on September 30th, 2015, and all of a sudden there was a government mandated change in language, so you had to change to speaking French. And that's really what it comes down to. Anybody that's been in practice, we cut our teeth on ICD-9, and now come October 1st, 2015, we have to learn a whole new language. And there's no codes that are the same. There's no one-to-one carryover in that regards. So that's the reason it's good that, first of all, it's good that you're here now, getting some foundation for you. I'm also going to recommend that you start, after we get done with this next section, that you start having weekly meetings with your office staff on going through ICD-10. I suggest that you do that after, every one of these webinars. You have a meeting and start discussing things on how your clinic can make this transition into ICD-10 and the roles with everybody involved. And it can be fun. I know some offices are playing some games. I know that we actually had a little competition with some of our seminars that we had tables versus tables regards who's going to get the correct code. So, okay, well, moving along now, let's get into the actual coding process. So how are we going to take our current ICD-9 codes and using a formula transition into ICD-10 or start to find an ICD-10 code? So the first thing you're going to do, you're going to start with a familiar ICD-9 code using General Equivalent Mapping System. And then if needed, you could look in the alphabetic list or index, and then finally you arrive at the tabular list. So under the 3-letter or the top level entry for any code in the tabular list, you may find notes about what the code may and may not be used for. So you may find similar notes in the sub-classifications. These are the instructional notes, and they are very important. And to get more information on this, if you currently have an ICD-10 CM for chiropractic from ChiroCode, go to page 28 and review those instructions. Some codes may include a list of terms following the original description. It's very important to follow these terms. All right, so now we get into when the word includes appears in the instructional notes under a code, it will have a list of similar conditions or different names for the condition, which is covered by that code. For example, other soft tissue disorders, M70 to M79, page 225. M70 is soft tissue disorders related to use, overuse, and pressure. And then it'll say includes soft tissue disorders of occupational origin. Use additional external cause code. So this is where you're going to have to go into chapter 20 and find the etiology code that caused this overuse and pressure. So again, this is nothing more than a big cookbook, and you're just following the recipe. Again, any excludes one is off limits. So if you have M70, soft tissue disorders related to use, overuse, and pressure, and there's an excludes one, you cannot use bursitis, M71.9, with M70. Excludes two, now you can take, and you have M70, excludes two. Now this is saying that these other conditions could be used. There are separate conditions, but you could code these at the same time. All right, so how do we find the ICD-10 code? All right, so what I want you to do is go ahead and fire up that find a code, because that's where we're going to get started. You know what? I'm going to get mine fired up here too, so
would it be all right if I
with you.
Would it be all right if I did the next polling question? And then we could do the other one at the end? Yep, go ahead. Yeah, okay. Everyone will
all right, that sounds good.
Multitask while they're firing that up. Hold down your CTRL key. I'll give you a second to do that. And while I give you a second, I'll do a reminder for those watching the recording. The polling questions are not interactive, so they're part of the test that came with email. So I am going to go ahead and launch the poll now. And so when looking up ICD-10 codes, you should always end at GEMS, alphabetical listing, or tabular listing. We'll give everybody a second to vote on that. 79%. There we go, 80. We have a few more who need to vote. Again, if it doesn't work, just type it into the questions box or send it to me later. 88%. We just got one or two that needs to get their vote in. And it's not, you're not graded on it, so give you a couple more seconds and I'll close the poll now.
All right. If you were one of the 82% that said tabular listing, you are correct. All right, you're going to start with either the GEMS or the alphabetical listing, but you're always going to end at the tabular listing. So let's take a look at this. Let's actually go through and see what we're talking about here. Okay, so 3 methods using Chiaro code. You're going to take the GEMS, which the find a code is general equivalent mapping. Or you can just type in the name of the diagnosis, but you don't stop. You always end at the tabular list. So just to give you a little practice here, if you're in find a code, I want you to go to ICD 9CM and select that. And that's going to give you 2 choices, browse ICD-9 or search. I want you to click search. And up in the search, I want you to type in or input in 739.1 and click search. And when you do that, it's going to come up with 739.1 somatic dysfunction cervical region. So when you get to there, I want you to click on that. Click on the 739.1 somatic, it's in purple, and that's going to give you the GENS. It's going to say the following ICD-10 codes are generally equivalent to this code, and it's going to go into M99.01. Okay, so that is taking you to, that's using the GEMS to getting you to the code. Now there are some one-to-ones that you would use. Let me show you this real quickly. So this is the actual ICD-10 complete for chiropractic. And they have a whole database at the beginning of the book with our ICD-9 codes right here. So we go to 739.1 cervical region, you come over to the right, and you see M99.01, segmental dysfunction of the cervical region. Okay, I don't recommend that you quit right there. That would be using just the GEMS, and you don't want to do that. You want to go to M99.01, and so bear with me. We're going to get way back here. And again, this is from the book. I went too far. Okay, so this is the tabular listing that I keep talking about. All right, now, so you get to the GEM, and the GEM gets you to the M99.0. Okay, so now we have segmental somatic dysfunction, M99.01. So you look right here, segmental and somatic dysfunction of the cervical region. Okay, so this is where you would end on. But let's take a closer look. Let's take a look at, so you see what I'm talking about. Let's say right here, you get to M43.0, spondylolysis, and you have your excludes 1 right here. So it says, okay, if you're going to use these codes here, you cannot use congenital spondylolysis, the Q76.2, and you cannot use spondylolisthesis, M43.1, with these guys right here. And you see how detailed we get in here now? So we have spondylolysis, cervical region, cervical thoracic. And let's just go down to spondylolisthesis again. So if you get to spondylolisthesis, so you look up and find a code, and you get to, it would say M43.1. Now you have to come into, this is the tabular, and you've got to follow the directions here. So excludes 1, you can't use these codes with any of these codes. And here's all our spondylolisthesis. So you see, doctors, why your documentation has to be spot on, because you have to identify the site now. And just to drive this home a little bit more, here's our excludes 2, where it says fusion of the spine, ankylosis, spinal joint. So you're not going to use these excludes 1, but these excludes 2 may be in there. But let's get to the M50s so you can really get the full flavor of ICD-10 here. Okay, we have our cervical disc disorders, M50 now. All right, here's our notes that we just got done talking about. Note, code to the most superior level of disorder includes cervical thoracic disc disorders with cervicalgia, cervical thoracic disc. So here is a perfect example of an ICD-10 code that replaces 2 ICD-9 codes. All right, so we have cervical disorder with myelopathy. Cervical disorder with myelopathy, unspecified cervical region, or high cervical region. So you see, very, very specific. Over here, we're talking about cervical disc displacement, mid-cervical, high cervical. Here, we're talking about cervical disc disorder with radiculopathy. So this is why you could put in your GEMS and get you to here, M50. That's why you can't stop here, though. You can't stop with the GEMS. You've got to get to the tabular list, because we've got to get this full, all these codes. There could be 5 codes right here, 5 characters that you need. So if you have a C5, C6 with radiculopathy, here it is right here. C6 radiculopathy due to disc disorders. So you see now where your motor examination, your dermatome examination, these are all, you're going to have to revisit these, because it's going to be very, very specific for your diagnosis. So you get to the GEMS, and then you get to the tabular. Okay, so to give you an example, there are some codes that have one-to-one mappings. That means there's one ICD-10 that equals an ICD-9. That's pretty much your pain codes. So 723 cervicalgia will go into M54.2. That's the same with your low back pain. Some have a 1-to-4 mapping. So we're going to have one ICD-9, but it could go into 4 different levels. So like right here, thoracic or lumbosacral neuritis. Now we're looking at possibly 4 different radiculopathies. So you got to go look at each one of these codes and make sure you have the highest level of specificity. Aren't you glad you're not taking care of non-union fractures? this code right here could possibly have 2,530 corresponding ICD-10 possibilities. Closest one to this for us is a soft tissue, and I'll show you that in just a little bit. Our sciatica, M54.3, unspecified site, M54.31 or 32 right or left. Or if there is low back pain with that sciatica, now we have this one right here. And again, M54.41 right or M54.42 left sciatica. So we have 2 ICD-9 codes being replaced with 1 ICD-10 code. So what you'll do is you'll look up the GEMS. So let's look up 724.3. Let's go through this in the ICD-10 book. All right, so we're going to start, and we're going to go back, way back up here to our GEMS in the book. And the GEMS in the book is the first, some of the first sections. So we're going to look up 724.3. And this is what you'll need to do. I would recommend you start getting your ICD-9 code you use now and start putting together your ICD-10 codes. Okay, here we go. 724.3 sciatica. That's going to take you over here. It's going to say unspecified because it just gets you going. So M54.30. So you're going to go to this section, this code right here. Okay, M54.3, sciatica, excludes lesion of sciatic nerve. So you cannot use sciatica with this code here, and you cannot use sciatica due to intervertebral disc disorder M51.1-. And you also cannot use sciatica with lumbago, M54. So we have these excludes. So now if you just have sciatica, no low back pain, no, we don't know what's causing it, so you don't know if it's a disc or not, you would stay with M54.31 if it's on the right, M54.32 on the left. So you'll see that right here. Look up sciatica. Now find it in the tabular list. And then you don't want to use unspecified too often because after a while that's going to start being investigated. Investigated means asking for notes. Okay, now with spasms of muscle, this is kind of interesting too. We have M62.40, contraction of muscle, and M62.838, other muscle spasm. Is this the end of the story? No. Okay. Look at all these muscle contractions or muscle spasms that correlate from 728. So let's go and take a look at 215. So we have all these, M62, contracture of muscle thigh. We have laterality. Okay, here's the one that you want to pay close attention. So right now, the two main soft tissue diagnoses we use are 728.85. As long as you have muscle spasm in your documentation, you're good to use that diagnosis. So we have muscle spasm of the back. This is going to be of the thoracic or the lumbar. If you ever wanted an ICD-9 for Charlie horse, our patients have Charlie horses, well, there isn't one, but there is here for ICD-10, muscle spasm of the calf, Charlie horse. This is what I mean. There's other notes that will say maybe some other wording for this, but here's the one that we'll use for the neck, M62.838, other muscle spasm. Because of the specificity, this is going to allow us to do it for the back. This will allow it for the neck. And then other disorders of the muscles, you're going to start, here's some of these other instructions here. So if you're going to use M63, disorders of the muscle and diseases classified elsewhere, so here it's going to say, well, first, make sure that you code the underlying disease that's causing this disorder, and it gives you some of the possibilities there. But then it says you can't use these codes, okay? So are you starting to get...
We've got a couple sciatica questions.
Okay, go ahead.
What if it is sciatica due to, Dr. Wondra, Piriformis? Piriformis?
Oh, piriformis. Excellent question. So what you would need to do is you would have sciatica. So I would say you would use your sciatica code, so that'd be your neurological, and then you would use your soft tissue. Let's go look at M62. Okay, so let's try to find that. So that's going to be a contracture of the muscle. Now, it's not going to list the specific muscle, but we can find arm, forearm. I would probably, and this is still non-traumatic, okay, let's say it was right sciatica, so I would do the sciatica, right side, and then if it's piriformis, I would probably use this right here, M62.451, contractural muscle, right thigh. Unless we can find, this is lower leg, muscle, thigh. I'm not seeing anything with the pelvic or buttock here. So this is what you would probably need to do. You need to take and start looking at these and picking the ones that you're currently using in your office right now. I would say that would probably be it right there. There's a possibility possibility that you may even would consider a contraction of muscle other site. So I'm not really seeing anything with the pelvis or buttocks. So maybe I would do that, because this is more of the, I'm thinking anterior thigh, right lower leg. Yeah, that's what I would go with right there. Okay, so you're going to have to brush up on some of the terminology and some of the things here, because you've got to be spot on with your documentation. And so osteophytes, you know, you need to, doctors, you're probably going to have to educate your insurance CAs on some of these anatomical and physiological responses. So you're going to want to get them into some anatomy. They're going to need that, you know. So for instance, we are starting a training session on Thursday, and I'm going to go over with my staff these pictures here, what osteophytes look like when it comes to narrowing the spinal canal. So we got spinal stenosis going on. What a left lateral disc protrusion would look like, or a central herniation, so that they start seeing some visual aids, so that will help them with the coding aspect. You know, some disc displacement, some tearing out here. What happens when a herniation or disc prolapse, where this actually erupts in and starts irritating the dorsal root ganglion. So you can start doing some anatomy and some visualization exercises. And now we're going to get into myositis. There's some inflammation due to the muscle. So you can start looking at page 209, M60.8.
Doctor, do you have a second to go back to sciatica and the gems?
Yeah.
We had another question, and maybe you got this addressed, let me know. Does the sciatica code get specific for the trajectory of the nerve to the knee or the ankle or the toes?
The sciatica, no, it doesn't. There's no code that says sciatica to the posterior aspect of the knee, or sciatica all the way down to the ankle. There's just sciatica right leg.
And then another question, wouldn't you get back to GEMS to find equivalent for Performia syndrome?
Let's take a look at that. I don't think, to get back to the GEMS, I don't believe there's going to be something that's going to take you right to, I know there isn't. There's not going to be something that's going to take you right to piriformis. The best you're going to be able to do with the GEMS is come here and go to 728.85. Because that's a muscle spasm. You guys see why you need to get the book? Because even the find a code is not going to get you where you need to go. It'll get you started on the journey, but it will not get you to the destination. And the price that Denise is offering is excellent. Okay. See, this is where it's going to go. You're going to start off here at 728.85, and it's going to say, well, you can start here at M62.40, and then that's when you go into the tabular list and you start looking at those headings, and from there you're going to have to find the most specific code. You know, unfortunately, they don't list it by muscles. So does that answer the question?
No other questions have popped up, so that must have answered. Oh, yes. She typed in yes.
Okay.
And
All
then
right.
before everyone leaves, we will have one more polling question. We'll probably do it at the very end. Just wanted to let everybody know. Thank you.
Okay. All right. Okay, so again, muscle spasm, and this is where the codes, the sections that it's going to lead you to. Myalgia. Myalgia is really our 729.1 ICD-9 code, and that'll take us over into, and that can be hypertonic muscles, muscle pain, soreness. So the etiology, this is really big in ICD-10, and I talked about this at the beginning. There's a lot of etiology codes that are available. For instance, Heelys. Heelys are those shoes that pop out and they have like roller blades in them, and these are actual codes for Heelys. So I'm not sure there was this table of people sitting around say, you know what, we got to get Heelys in here because I'm seeing, an epidemic of these. But this is the kind of things that they have. So let's go through some examples. I was hoping I could. The video's not going to play. Well, we'll move right along because we're starting to get close on time. Okay, let's talk about episode of care. And this is a, hint here on episode of care. Traumatic conditions will require a seventh character extension, which will consist of one of the following. So when you see that extension here on any of the codes that have this little underscore, you have to put the seventh character. Okay, so for our traumatic subluxations, on the initial exam, the initial encounter, you're going to put A. So right here, for example, S13101A, dislocation of cervical vertebrae, initial encounter. On the next claim, when you do a treatment or in the subsequent encounter, I'm going to recommend that you put D. You have to change it to D or S. S is sequela. That is a residual. So if you think a patient is presenting with traumatic subluxations that's a residual from an earlier trauma, you would use S. I'm going to recommend you don't use that very often because the auto carriers and work comp will start questioning pre-existing condition. So I'm going to recommend that you use D, subsequent encounter. So again, whenever you see the underscore in the seventh character, the initial exam or the initial encounter will have an A. On subsequent visits, that'll be changed to D. And that is called an episode of care. And you'll see that the code book will give you the instructions to do that. Okay, what to code first? All right, so your hierarchy, if this was Medicare, you'll do your subluxation, and then you'll do your neurological subluxation, structural subluxation, soft tissue. I don't use functional very often, so I mainly stay with neurological, structural, soft tissue, and pain. And you will do that for each of your complaints. You'll list the diagnosis. So I would recommend that you start doing that now with your ICD-9 codes. We don't know, again, regarding subluxation or dislocation. The payers will decide if subluxation or dislocation or if they want the most severe diagnosis. So we're kind of wait and see how that pans out. Chapter 3, musculoskeletal documentation. There are now whole books just written about the documentation requirements for ICD-10. And I can tell you that I'm writing my third book specifically on this for the chiropractic profession. So when this gets that gets done, I'll be sure and let you know. But the documentation drives ICD-10. There are some vocabulary changes. Neuritis and radiculitis now are changed to radiculopathy. Backache in some instances is dorsalgia. Spasms to contracture, and facet syndrome is now listed under dorsopathies. You have to put in the sites of injury. So in the cervical spine, these are the sites that you must document. In the thoracic spine, these are the sites. And in the lumbar spine, these are the sites. So, site-specific, laterality, condition, acute or chronic, and then episode of care. So you want to put down acute traumatic or chronic conditions. You know, if it's a recurrent or chronic condition, typically it's going to be found in Chapter 13. Acute injuries with known mechanisms of injury can be found in Chapter 19 and in Chapter 20. So various conditions that we'll deal with, osteoarthritis has multiple codes and multiple categories. So you'll be looking at M15 through M19. There's also specific codes for primary and secondary OA. And again, in the extremities, we're going to have laterality coming into play. So in this case here, we have a 61-year-old female presents to the office with right hip pain. She had a soft tissue injury to her right hip 6 years ago following a bicycle accident. X-rays at the time were negative for fracture. Today, she has tenderness to palpation in the right hip, positive Patrick's test on the right, reproducing the hip symptoms. X-rays of the left hip were unremarkable. However, the right hip showed sclerosis of the superior aspect of the acetabulum. So the diagnosis written out is post-traumatic osteoarthritis of the right hip. Post-traumatic because she had this, it was injured 6 years ago. So if we were to do, and I put in a subluxation or segmental chiropractic, so M99.06, and then there is actual an M16.51, unilateral post-traumatic osteoarthritis of the right hip. So this is why I put this in, and in later sessions I'll talk more about case examples because I want you to see what kind of documentation is needed. This is why you really have to get into an electronic health record system because you just can't keep up with the documentation demands of ICD-10 with a travel card or handwriting your notes. Spondylosis. Spondylosis is a stiffening or fixation of the vertebral joint with fibrous or bony union across the joint resulting from a disease process and affecting the vertebrae, intervertebral disc, and soft tissues of the spine. It can cause radiculopathy and myelopathy. So you're going to go to page 201 and start off at spondylosis, M47, and see what's the most appropriate code. You know, so you're going to have to document the symptoms. Is it a radiculopathy? Is it facet-mediated pain? Is it myelopathy or spinal artery compromise? You know, so now you have to identify the conditions. And then you have to identify the site because each one of these is going to determine the most correct ICD-10 code. And here's a brief example of that. intervertebral disc. This is a whole there's a whole gamut of things here with disc disorders. So M50 starts it off with cervical disc, M51 for thoracic and lumbar and lumbosacral. You know, you have to clearly document the condition. Is there myelopathy, radiculopathy? You know, is there just sciatica? Is there no low back pain? I mean, is it disc displacement? Is it a disc protrusion or herniation? This chapter in ICD-10 for disc disorders is huge. Okay, so in your notes, I want you to start taking and looking up these codes. So you can use the gems to start this. You know, we've got about 4 minutes, so I want you to, this is the kind of games I want you to start playing. Pick out your ICD-9 codes and translate them to ICD-10. So in this case, it would be M99.01. 839.04, this is a traumatic subluxation of the fourth vertebrae on the initial visit. That would translate over to S13.141A, because that A is the initial visit. Brachial neuritis or radiculitis from cervical region. Okay, and even this, you know, even going back to ICD-9 now, this doesn't even really cervical region. ICD-10, is it upper cervical, mid-cervical, lower cervical? Lumbar spine pain carries over to M54.5. Muscle spasm. Degeneration of lumbar intervertebral disc. Okay, so I'm at an end. I believe there's one more polling question. This is our contact information here. So start taking your ICD-9s and going in and translating the ICD-10. Start doing that, and then next week we get into more about specific documentation, and I'm going to go in very heavily next week on the vertebral subluxation complex and how to use ICD-9 right now, and then ICD-10 that substantiates our vertebral subluxation components. So, Denise, if you want to go ahead and do the final polling, and then I'll take some questions.
I will do that. If you hold down your CTRL key, I'll launch the poll now. And which is not an episode of care? Which is not an episode of care. We're at, almost everyone's voted. I think we just have a few more. I'm going to close the poll in a few seconds. So, and again, if it didn't pop up for you, just send it to me. Okay, I'm going to close the poll now.
Okay, the episode of care, for those of you who said close encounters were not, you're correct. Your episode of care is A, initial encounter, D, subsequent encounter, and S, sequela. So the sequela, again, if there is any residuals from a previous trauma, then you can go ahead and use that. Okay, I do caution against it if you're using it on a auto or work comp, because they can take and come back and try to hit you with pre-existing condition. So, any other questions from today's session?
We'll give it a second in case someone's busy typing.
Sure.
And you have your website there, your contact information. That's great. If anyone does have a question, they could send you a quick email if they think of something later. And I'm sure that, of course, there's a lot more to come. We have 3 more 2-hour webinars, so we'll look forward to those. And it doesn't look like anything's popping up.
Okay.
All right.
Well, thank you again for attendance today, and I look forward to talking to you again next week.
Thank you so much.
All right. Have a great day.
You
Bye.
too. Bye-bye.